Greetings, everyone. Welcome to AHRQ's web event on clinical community relationships as a pathway to improve health. We're so pleased to have you with us today. I'm Janice Ginevro from the Agency for Healthcare Research and Quality, and I'll be moderating the webinar today. I'd like to begin by describing the flow of the webinar. First, I'll provide some background information on AHRQ's interest in this area. Next, I'll offer a few tips regarding webinar logistics. Then I'll turn the presentation over our two speakers and open the floor after they speak for questions. Last but not least, we hope that you'll complete the webinar evaluation form that will be available at the end of the presentation. AHRQ's Prevention and Chronic Care Program has invested in a multi-year, multi-phase initiative to explore what's known about clinical community relationships and their role in improving care and improving health. A focus of this work has been our interest in understanding what is needed from the perspectives of methods, data, and process to build an evidence base regarding the effectiveness and efficiency of clinical community relationships in delivering appropriate clinical preventive services. The current phase of this work, which we will describe today, was led by a project team that included investigators from WestStat, Oregon Health and Science University, and the Oregon Rural Practice-Based Research Network, and also by an expert panel that will be described in detail later in the presentation. Clinical community relationships hold the promise of improving care and improving health outcomes. AHRQ operationally defines clinical community relationships as forming partnerships and relationships among clinical, community, and public health organizations to fill gaps in needed services, coordinating healthcare delivery, public health, and community-based activities to promote healthy behavior, and promoting patient, family, and community involvement in preventive health care. As I mentioned earlier, the current project is part of a larger initiative, and our specific focus on the measurement of clinical community relationships grew out of several stakeholder events which AHRQ convened to inform the clinical community relationship research agenda. Participants in a summit held in 2010 identified strategies that they, as a group, believed to be high priority and actionable. The top priority strategies identified by the stakeholders were to develop metrics related to linkages between clinical practices and community organizations, to identify how linkages contribute to better outcomes, and to promote research competencies within community-based programs to understand the outcomes of primary care and community linkages. And now I'd like to introduce the specific purposes and processes of today's webinar. As a result of your participation today, it's our intent that you will understand the concept of clinical community relationships and the rationale and need for further investigation of measures. Learn about the processes used to develop the Clinical Community Relationships Measures Atlas and Roadmap, and hear about the application of these products to research, evaluation, and public health practice. Now just a few quick points regarding the webinar console. The console can be resized to fit your entire browser window. We're pleased to offer closed captioning on this web seminar. To access the closed captioning, please click on the link called Closed Captioning that is on the lower right hand of your screen view. After you click the link, a new window will display the captioning. I'd also like to remind you that if you experience any technical problems, you can click on the question mark button at the bottom of the screen to access the help guide, or click on the Q&A button at the bottom of the screen to contact us with your question. Our technical staff will work with you to resolve any issues. The last 15 minutes of this web event are reserved for a discussion based on questions that you submit. Questions may be submitted at any time during the presentation. Simply click on the Q&A button at the bottom of your screen, then type your question into the box and select Submit. We welcome your questions and comments on the upcoming presentation. You also have the option to download slides from this console by selecting the Download Slides button for the PDF version of this presentation. We're very fortunate today to have as our speakers two members of the expert panel that guided work on this project. Our first speaker will be Dr. Rebecca Etz, who is an assistant professor in the Department of Family Medicine at Virginia Commonwealth University and recognized as a Presidential Faculty Excellence recipient. Dr. Etz is a cultural anthropologist with expertise in qualitative research methods and design. Her research focuses on mental and behavioral health in primary care settings, practice redesign, and the promotion of improved patient-centered care through innovative uses of health information technologies. Our second speaker is Bobby Pestronk. As Executive Director for the National Association of County and City Health Officials, or NACCHO, Mr. Pestronk represents our nation's local health departments and their staff who protect and promote health, prevent disease, and seek to establish the social foundations for wellness in nearly every community across the United States. Prior to his position at NACCHO, he served as health officer in Genesee County, Michigan for 22 years. Mr. Pestronk is a member of the board of directors for the Ruth Mott Foundation. Rebecca and Bobby both made very significant contributions to this project as members of the expert panel, and I'm delighted that they are with us today to describe this work from their perspectives as researchers and public health practitioners. So Rebecca, over to you.
Thanks, Jan. It's important to know, I think, from the outset that we really wanted to develop a tool that would help researchers interested in clinical community partnerships. We wanted something that would encourage such partnerships, something that would help to develop, strengthen, and sustain them. So we firmly believed that strong partnerships between the clinical offices and community resources would allow for an enhanced ability among primary care practices to provide care for their patients and to promote the healthier behaviors we know lead to better quality of life and reduced disease burden. I think it's clear that primary care cannot do it alone. A great deal has been published about the number of hours in the day and per visit required to deliver all preventive services as recommended. So partnering with community resources in meaningful relationships is one way to allow practices to virtually expand their hours and to extend their reach beyond the clinic walls that may limit the services and intensity of care delivery we know can be optimal. The first 4 bullets under purpose are ones that I know the full group would agree with. The 5th bullet is part of what motivated me to become involved in this project. There are persistent obstacles to the delivery of care that frustrate many of us, and I think most of us would agree that fragmentation is the biggest offender. Relationships among those involved in care delivery create a natural bridge to mend that fragmentation. Centering on the connections between clinical settings and community resources is one way to build an integrated medical neighborhood able to fulfill the social contract of primary health care. In other words, care that takes full advantage of a delivery system that rests in the context of where people live, work, and play. So I've organized today's presentation, or at least my part of it, around the things that we did in order to complete this project. From the lit review to the conceptual framework and to the involvement of the expert panel, I plan to walk you through how we developed the atlas, the work on which we're building, as well as that which we need to create. Perhaps most importantly for the researchers in this webinar, I'll end with priority questions and future directions our team generated as a result. Guided by AHRQ, WestStat, and colleagues from the Oregon Health and Science University, there were parameters to our work that are important to understand. I think it will help everybody to create clear expectations here regarding both what the atlas is and what it isn't. We all know, we've done this work before, that it's sometimes hard to accept study constraints. I know I typically try to resist them, but they're often necessary, and they're an important part of containing and advancing what is usually a complex conversation. You will see from these, you will see some of these return when we discuss the priority questions and recommendations further on. The list of assumptions I review here is abbreviated from what you'll find in the atlas posted online. First, we began with prevention as it originates in primary care and is directed outward. And yes, this is clearly a point of struggle. The conversation around prevention is far more dynamic than that, and we both realize it and support the idea of prevention that originates in other areas. This is only one vantage point to the conversation, but it's an important one and a critical step for improving primary care delivery. We were struck by the difficulty and the need for organizations, community organizations, and area residents to have equal roles as agents in that conversation. But having the limit of going from primary care outward allowed us to ground our discussion. The potential otherwise for it to grow in abstraction and become less useful as a result was pretty real. Second, in our list of assumptions, we're in such a moment of growth right now in research and care delivery that some of our most basic terms are used in incredibly expansive ways. It can make them unwieldy, and so we found a real need to define some of our most basic terms. Perhaps most important for this webinar are the definitions of community resource and clinicians. Community resources as places that do not provide clinical preventive services. Here we were really trying to limit our scope in useful ways that would allow us to purposefully exclude specialty care and lab settings from our discussion of community resources. Second, it's important to note that we talk about clinicians and not providers or physicians. Clinicians here, really, we intend to include such categories as nurse practitioners and other clinicians that you might commonly find in a primary care practice. Third, it was important that the services identified could be feasibly delivered in non-clinical settings. This was another place in which we struggled. It limited our ability to develop an atlas of measures that embrace the importance of context and the really great prevention work that focuses on the impact of the social determinants of health. I think that pull is probably a natural outcome of a moment when primary care and public health are becoming more and more integrated, and we're looking for a new language that will facilitate that process. Since we're not there yet, we took our guidance here from the U.S. Preventive Services Task Force and limited ourselves to the non-clinical preventive services that received A and B level recommendations. These included counseling relative to alcohol misuse, tobacco use, breastfeeding, healthy diets, obesity and obesity screening, and counseling related to sexually transmitted infections. And in the end, I think that this is okay. If we believe in the concept of holarchies, in which each system with which we work is both complete in itself and nested in a larger system, then it's meaningful to focus our efforts on one system in isolation, so long as we are cognizant of the impact and interaction that it has with those larger or neighboring systems. We really see this atlas as a first step on which others will be built. Naturally, they will be able to encapsulate and expand on this foundation that we're establishing. The fourth assumption within our framework relates to patient outcomes. By grounding our inquiry within the clinical community relationships that improve care delivery and are responsive to patient needs, specific attention to patient outcomes are excluded from our framework. If you look at the atlas, you'll see a fuller set and description of the assumptions we identify, but I believe these are likely the most important for understanding our work while listening and watching this webinar. The atlas represents new formulations and new ground, but it's also necessarily grounded and inspired by work that's been done before. Our team started our work with a targeted lit review that went 10 years deep and covered 4 databases based on a diverse set of search terms. What came out of that process was a large set of relevant articles and a critical subset that became the foundation of both our conceptual framework and the measures we later identified. For the framework, we were informed by the work of 3 people in particular. We thought about Arthur Himmelman's model for understanding the ways in which people work together. It was clear to our team that the 4th level he describes, that in which people share information, alter their activities as a result of what they learn, share their resources, and become invested in enhancing the capacity of each other, was the way we wanted to go. That was the core of clinical community relationships: sharing information, altering activities, sharing resources, and being invested in enhancing the capacity of each other. It's not likely that a surprise that Donna Bedian's model is one on which we would rely, as it seems to be a mainstay. But I think it's important that we be explicit about how we applied his model. For us, the structure in his model in question was the concept of care delivery. Process for us was the action of providing preventive services, and the outcome of interest was the engagement of clinical and community partners. From the bridging model, we were drawing on 2 things. First, that certain characteristics need to exist within community resources and within primary care settings in order to enable successful partnerships. And second, that we orient our vision to allow for documenting and assessing the strategies used for creating successful dynamic connections. What you see here on your screen is the bridging model. And I realize that this may be hard to read for some of those attending this webinar. It's lifted right out of the American Journal of Preventive Medicine if you're interested, and the citation's there on the screen. While creating this model, one of our biggest drawbacks was a lack of access to information about patients. The data informing this model were generated from the evaluation of Prescription for Health, a national study involving over 300 primary care practices. As the evaluation team on which I served, we only had access to information as reported by participants. Call it the missing link, but a bridge without traffic or patients really does fall apart. So this project adds the much-needed detail of the patient element, looking at the overlap of patients, clinical settings, and community settings. Through the Atlas, we created a model that includes patients and therefore allows us to develop measures that best enable our understanding of the dynamic relationships that inform delivery of non-clinical preventive services. Our model, as illustrated, is based on 3 elements, intersecting domains among those elements, and the dynamic relationships in the middle that keep this bridge a living connection. For our purposes, the domains are organized around Donna Bedian's model, while the elements represent an enhancement of the anchors found in the bridging model. Were you to visit the Atlas, you would find a matrix using the same terms and looking something like this. You see the domains expanded along the x-axis on the left, while the elements and relationships appear on the y-axis on the top. Making Donna Bedian's model functional within our framework yielded 33 domains. You'll notice when you see them that they're informed by 2 models, particularly the socio-ecological model, or how an individual is situated within a system, and the expanded chronic care model, in which functional areas that enhance team-based care delivery are highlighted. Though this matrix could yield a possible 186 measures, we determined only 56 categories made sense. As part of the literature review I mentioned, we were able to identify 22 validated instruments previously published and have included them in the Atlas. But more on that in a moment, as this is the point at which the expert panel became a critical element to our collaborative project. You can see the expert panel listed here. It was comprised of a fairly diverse group of people, all of whom, I'm glad to say, had a great sense of humor while they did their work. They held in common a real boots-on-the-ground kind of experience and exposure to a wide range of primary healthcare delivery systems. Their multidisciplinary conversation wasn't always easy, but it was purposeful and managed to add greater coherence to what we found in a fairly disparate literature. This was a nice moment of luxury in which we were able to stand back and reflect on a body of literature as a whole, and that's time we really don't often get to spend. I'm really glad that this can advantage other people. The result of our work was published by AHRQ this past March and can now be found online. It includes all the things I've discussed so far, the logic of our framework, the measures we were able to find, and how those align with the framework rationale. When a measure is available for a particular category, you'll find a hyperlink in the atlas that connects to an information page about that measure. What you see here is one such information page. It includes important background information about the measure so that you can easily assess if it will fit the needs of your work or project. And if it does, there's a hyperlink available that connects you directly to the validated instrument with permission of the author. I really think that this is one of the coolest features we created in the atlas. Now what I have here is a modified version of the matrix that you see in the atlas. On the left, I list the 10 domains for which we were able to find existing measures. In the body of the matrix, the yellow boxes show under which element or relationship that measure exists, along with the number to indicate how many measures we found. Notice the heavy focus here on clinical patient relationships, on the referral process, and on the knowledge base of the clinician. The relative lack of information regarding patient and community resources. None of these concentrations or gaps should be surprising, given the focus of past research and funding opportunities available to primary care. Fortunately, that picture is beginning to shift. Now, for those of you out here who are doing the math, with 56 possible categories to fill and only 10 existing measures, the next step for our team was to begin the process of filling in the remaining categories with candidate measures. That report is now posted as of July and can be available on AHRQ's website as well. It is our intention that both of these products, the Atlas of Clinical Community Relationships Measures and the Evaluation Roadmap, help researchers within primary care, among community organizations, and among those involved in stakeholder engagement work to advance their work in ways that begin to heal the fragmentation that plagues our system. The framework of the Atlas is particularly instructive in the ways it orients research design and potential points of data collection such that the impact and value of clinical community relationships is both tangible and measurable. As I mentioned in the beginning, our work on the second deliverable of this project, the Evaluation Roadmap, concluded with the identification of 5 priority questions. You have them on your screen, but I think it's worth reading through them. How do the characteristics of each of the elements in our framework, primary care clinicians and clinics, patients, and community resources, influence the effectiveness of linkages for the delivery of non-clinical preventive services? Likewise, how do the characteristics of the relationships among those framework elements influence the effectiveness of those same linkages? How does the relative importance and influence of both elements and relationships as described in our framework vary based on different circumstances, in different contexts, or in differing delivery systems? What are the best methods, strategies, and setting to conduct and improve these relationships? And what are the best measures for evaluating the effectiveness of those relationships in particular? Also from the Evaluation Roadmap are 7 recommendations for future research. Highlighted here is the complexity of the dynamic we hope to inform, the necessity for flexible research designs, and really the need to develop standardized measures in this area and to disseminate our findings in new ways. I'd like to reiterate that this framework is intended as a starting point to facilitate new kinds of conversations, and we hope that it will foster such work. I really thank you for your time today and would like to now turn this presentation over to Bobby Pestrunk.
Thanks, Rebecca and Jan. As the Executive Director of NACCHO, I was pleased to be a member of the expert panel because NACCHO's long-range vision is health, equity, and security for all people in their communities. And our mission is to be a leader, partner, catalyst, and voice for local health departments. Thought leaders in the public health domain, that is, those who are thinking about ways to create an improved health system, making use of the assets, tools, and resources within communities, have spoken of the need to better integrate the practice of primary care with the work of local health departments. So the Atlas and Roadmap are important to the National Association of County and City Health Officials for a number of reasons. Among them, they give us tools to share with our members. These tools can help us and our members conceptualize an evolving public health and clinical care system, recognizing ways in which community practitioners like local health departments, clinical practitioners, community organizations, and researchers can understand the progress of that evolution and also formulate, characterize, and document their roles as that evolution proceeds. The Atlas and Roadmap will help advance an understanding of these important yet evolving relationships, which are now hypothesized to make health easier. We know well the importance of relationships as a channel to stimulate change and to maintain the status quo. And we also know that relationships form, sustain, fail to develop, or perish, and we need to know more about why this is. The Roadmap and Atlas are designed to promote conversation. Conversation builds relationships, and these will help NACCHO work with other national associations, those representing clinicians, clinical care, and community organizations, and with our own members as they work in their communities to better understand and lower barriers that impede more effective communication and relationships. The Roadmap and Atlas also provide a framework for researchers and practitioners together, which can help form and test hypotheses about the effective relationships among public health departments, other community organizations, and primary care practitioners. Because the Atlas and Roadmap are sourced by AHRQ, I hope they'll encourage an increasing recognition within the clinical and research domains of the importance of the work, position, and roles of community organizations like local health departments in the successful universal delivery of clinical preventive services. And the Atlas and Roadmap are now present as well to guide the formation of research agendas by young public health and clinical services and systems researchers. Health can and should be easier. If international data are a benchmark, health can be less expensive too, or greater value can be returned from current expenditure and effort. Tighter integration between community and clinical practice can help focus efforts to make health easier. The Atlas and Roadmap are specifically concerned with the successful delivery of clinical preventive services. Successful and universal delivery of these services is consistent with the goals of public health practice to prevent disease, promote health, and keep people safe. Clinical preventive services are delivered now within a community setting, yet our nation's communities are diverse in demographic, economic, social, and political form. Each community is complex with respect to the constellation of assets available to deliver clinical preventive services. It's easy to picture the vast differences in assets between the most rural areas of our nation and the most urban. The Atlas and Roadmap ask us to understand this diversity, this complexity and variation. Community, as referenced in the Atlas and Roadmap, is a general term standing for numerous types of individuals as well as public, nonprofit, and private sector organizations, as the figure on the right illustrates. Many of these organizations and individuals can influence decision-making about and delivery of clinical preventive services. Primary care practice, too, a major clinical locus for the delivery of clinical preventive services, is also complex and accessed differently from community to community through, for example, community health centers, independent practices, and organized groups of physicians operating collectively or under the aegis of a larger health, hospital, or insurer organization. Shared metrics from the Atlas may help us understand how relationships vary by form of practice. Local health departments themselves have a jurisdictional presence within every community nationwide. They have a legal responsibility to keep people safe and make health easier through the general roles of assessment, policy development, and assurance. Their foundation rests on the use of science and politics to understand the cause of disease and of poor quality of life, and with that understanding to take the steps necessary to prevent disease and improve quality of life. The Atlas and Roadmap provide one framework for understanding these roles, providing an initial conceptual framework for documenting the relationships between clinicians and communities, and for measuring the relationships and characteristics of those relationships. As the Affordable Care Act introduces experiments designed to reduce cost, improve the quality of care, and increase access to care nationwide, it is at the same time, through the clinical lens, giving attention and credence to prevention. It's placing financial incentives to operationalize the idea that health should be profitable and illness in many cases is preventable, the result of our individual decision making, but influenced by the setting in which those decisions are prejudiced and made, and as a consequence result in a large burden of unnecessary cost to us as individuals, to the places we live, work, play, and pray, and to government, whether local, state, or national. It recognizes in its own way the social conditions which make health difficult and seeks to remedy that situation. Over the last 5 years, as the recession eroded approximately a quarter of the jobs in state and local governmental health departments nationwide, local health departments and other community organizations have had to reconsider the allocation and use of their scarce resources. Some local health departments have maintained, some are looking to expand, and even some have expanded their delivery of clinical and clinical preventive services. Others have increasingly divested themselves of these services, recognizing the capacity and responsibility for other practitioners to provide them. The use and the subsequent evolution of the Atlas and Roadmap over time can help us understand this evolution of practice nationwide and community by community. The Roadmap offers guidance for how the tools of science can generate information needed for better public health and clinical practice. It provides a context that may be essential to understand how to increase the likelihood that clinical preventive services will be delivered successfully to all who should receive them. The Roadmap reinforces the idea that clinical preventive services can be delivered and reciprocally referred among the formal clinical and community settings, that service providers outside the clinical setting can both influence the use of clinical preventive services through information and referral and by the direct delivery of those services. The Roadmap recognizes that clinicians and clinical practice are embedded in a larger system of rules, regulations, organizations, and partnerships. The Roadmap and Atlas offer guidance on and ways to measure the nature of collaboration, suggest the use of metrics to incentivize movement towards recognition and use of partnerships, and of the need to establish relationships so that clinical preventive services can be more universally accessed and delivered. Its use by clinicians can help orient them to life outside the office, which influences the health of their patients and the likelihood of compliance with advice and recommendations in profound ways. The Roadmap recognizes the important meeting place among three very different practice cultures, that of public health, primary care and research, and encourages greater shared practice and learning among them. One can see in it the place where ideas of population health and clinical care overlap, a through-the-looking-glass approach where more successful delivery and receipt of clinical preventive services on a person-to-person basis contributes to improving population health by informing and augmenting through relationship building, shared information, assessment, and community improvement processes work to change the social determinants of health, which themselves influence population health by making decisions about health and the receipt of clinical preventive services either more or less likely, easier or more difficult by design, and therefore default. The more people who gain access to clinical preventive services, particularly but not exclusively those associated with primary prevention, the greater the likelihood of preventing bad health and its associated costs from happening, or of identifying bad outcomes in their early stages. The more illness identified early, the less need for complex and expensive care later on. The roadmap suggests a means to improve quality, that is, to improve the likelihood of clinical preventive services being offered by encouraging effective relationships across domains. They reinforce the idea that organizations and personnel in the public health and clinical domains should play together better than they do now, with salubrious results. For sure, learning how to make the delivery and receipt of clinical preventive services more prevalent from various perspectives, clinical, personal, and organizational practice within a larger policy, community, state, or federal context is important. So too is determining what financial resources are necessary to establish and sustain clinical community relationships, especially from my perspective, those involving local health departments. Discovering and applying the best deep qualitative methods and formal quantitative designs to understand clinical community relationships will continue to be important. Through translational research, distributing and making more prevalent a culture of best practices will also be critical. We'll have to bring together practice-based research networks in clinical care and public health and help them play well together using community-based research principles which have been so well articulated and with which I have my own successful experience. Like this picture, time and friction will be needed to create beauty, and the path will be filled with twists and bends. Community clinical relationships nest in a larger network of activity necessary to make life and health easier and more productive for us as individuals and a nation. Community clinical relationships at their micro level can affect the social determinants of health, which have increasingly and regularly been demonstrated to be powerful levers to change life outcomes. This will require more clinicians to use their special status in society and weigh in on those aspects of life that make and keep people sick. Social determinants such as economic stability, education, civic participation, discrimination, neighborhood culture, housing, public safety, and the built environment generally predispose experience, incentives, behavior, and health or illness. By recognizing the importance of community for the successful delivery of clinical preventive services, the roadmap and atlas raise the visibility and importance of these social determinants within the clinical and public health domains. Social determinants make either equity or inequity possible. The social determinants of health are under our control over the long term. Inequity, a consequence of both personal decision-making and social determinants, makes health less likely, life riskier, and quality of life poorer than it should be for a nation as wealthy as ours. Inequity also inflates medical care costs, and it medicalizes social problems unnecessarily. Successful efforts to form and reap the benefits of community clinical relationships are one step in the right direction. The roadmap and atlas will help us practice difficult tasks and give us the courage to work on even more challenging issues and to use the relationships that form to address difficult issues. As research proceeds, it may become clear that health inequity, a present state of affairs, is of our own making, through both intentional design and default. Science and further research are necessary, but will be needed in the service of better outcomes. Through research, intention, and continuous improvement, we can achieve better outcomes. A study of our own nation's history reaffirms this faith. Thanks, Jan. Let me turn it back to you now.
Well, thank you, Bobby, and thank you also, Rebecca. And now, as we turn to questions from the participants in the webinar, I'd also like to remind folks that the information here is not an official policy statement from the Agency for Healthcare Research and Quality or from the Department of Health and Human Services. So the questions that you hear, the answers that you hear, the statements that have been made are the opinions of the individuals making those statements. So the first question that I have for Rebecca and Bobby is, do the speakers have any suggestions about how primary care researchers and public health researchers can collaborate on clinical community research questions? What's the first step in building a research partnership? And Rebecca, I'll toss this one to you first.
Thanks, Jan. It's a good question. It's a hard one to answer, but I think the starting point for any such collaboration has to be the people from the organization and the clinic getting together and listening to what the mission is and what the needs and motivations are for bringing the other person to the table. So you want to find out from the person or organization with whom you want to partner what it is that they're most invested in and why it is that they've come to you for help. And usually you have a joint interest in improving population health of some kind, but the missions can differ. So if you understand clearly what a person's mission is, as well as what their history of trying to address that mission might be, you can start your working together by building on the assets you both bring to the table rather than starting with problems or things that aren't yet there. And I think building on assets is one of the best ways to start that kind of relationship.
Great.
If I could add to that, I think that using body parts and technology is important. And what I mean by that is to walk over and talk with someone from another culture or from the other side. Use the telephone, if one still uses that, to call up somebody who is from another culture and express interest in their culture and set up a meeting to talk with them. Or use the range of electronics that are available. One of the most interesting experiences I had as a local health official in Genesee County, Michigan, was walking out of our clinic one day, and which was up in the northern part of Flint, and standing in the parking lot chatting with another one of my staff people and looking across a field and noticing that there was an elementary school across the field. And I asked the staff person who was with me whether anyone from the clinic had ever gone over and talked with anybody from the elementary school. There we were, providing a range of clinical services, maternal and child health services. It turned out that nobody had ever walked over there to chat with the principal or talk with a community liaison person. I think that story is relevant to the development of increasing interactions between the public health researchers and primary care and clinical researchers. Most of the people who are involved in that work are very interesting people with interesting agendas, interesting stories to tell, interesting collections of assets, as Rebecca has mentioned, and sitting down to simply have a conversation and talk about what we might be doing together, I think is the most important first step. I think you'll have a good time. I think you'll be challenged, and I think you'll find the people that you're talking with very interesting.
Great, thanks, Bobby. And here's a question that I think is a follow-on to that, which is how can state health departments collaborate with healthcare systems to support or identify these connections?
This is Bobby. I think that the same response is important here. It's interesting. I think that both state health departments and the clinical organizations both need each other because of the way the current healthcare system is evolving. There are both formal, structured meetings that are taking place around a whole range of issues, whether those are policy issues related to the Affordable Care Act and the changes that that's forcing in the systems, or in regulatory areas that the state health department may be engaged in, and setting up time, reaching out from one direction or another, from one organization to another, simply requires somebody to think that that's important to do and then to reach out and make the call.
Great, thank you. And now a question for each of you. Could you describe one example of a successful community public health clinical partnership? Rebecca, why don't we turn to you for this?
Sure. Hi, thanks. Sure. There's a really interesting collaboration that I think is going on in the University of Wisconsin in Milwaukee. The School of Nursing there, which has many nursing centers where they offer primary care, actually opens up their primary care centers within public health offices, so that as people come in for various needs, their motto is they trip over a nurse when they get here. So it's staffed with nurse practitioners, and they're able to work with public health because they're located in the same building, really understand each other's needs, and they constantly refer back and forth, which for them is really up and down the hallway. A result of this connection, though, is that they have gotten a lot of goodwill and support, not just between each other, but also with the people who live in the area. And one thing that they were able to do as a result of their connection was they actually submitted a grant to the EPA based on concerns that both sides, public health and primary care, were hearing from residents about the really high rates of asthma in their community. And they actually got the grant. They determined that there were toxins in the public housing material that people were living in, and they were successful in creating new housing. So it was a really interesting example of the primary care setting being able to extend beyond their walls and work with public health and with patients who were actually, just people interested in their health to advance a community-held concern. Great, thank you. And Bobby, any examples that you can think of?
I'd actually like to reference work which is beginning and perhaps underway in many communities across the country. And that's, again, stimulated by particular language in the Affordable Care Act, which is requiring nonprofit hospitals to work with the community and the local health departments or public health practitioners in the community to better define what community benefit status looks like. And it's requiring clinical and public health people to get together to do a community health assessment to determine collectively what the major issues are, major health issues and public health issues are in a community, and then to follow that with the development of a community health improvement plan, which will be, if it's done well, I think, a bucket of resources that are contributed not only by the hospital but by other organizations in the community to specifically address what the community and the hospital and the public health people in the community think are the most important issues in that community. What a successful clinical community partnership will look like here then is the development of not only the relationships across these three cultures, because I think that those who will be doing these assessments and creating these improvement plans will also want researchers to be involved to help document what's going on and to discover what's working well and what's not. But these processes will also engage the larger community in the process of determining priorities and seeing that the public and private and nonprofit systems that should and can work more effectively for better health in their community are actually using their assets for that purpose. One can see a very beautiful, virtuous cycle beginning as these processes are undertaken and are repeated in communities to build a constituency for better health, to one by one remove the barriers for better health in a community, and to build back the trust between people and organizations in a community, which is so essential for longer-term better health.
Thank you. And we have time for one last question. In this work in the Atlas and also in the evaluation roadmap, the focus has been on a specific subset of clinical preventive services. And this question asks what types of services, perhaps in general or beyond clinical preventive services, are best delivered through clinical community relationships. Bobby, would you like to take that one first?
I don't think that there is a health outcome or a desired health outcome for a community as defined by any community that wouldn't and won't benefit from improved community clinical partnerships. I think that in addition to the assets and the expertise that the clinical and community organizations and researchers can bring, as I mentioned, the identification of specific services that are important to people in communities can be identified as well. So I think that the clinical community relationships around primary care are an entry point for more difficult challenges and for other challenges that are identified by the evolving partnership.
Great, thank you. And Becca, any thoughts on that question?
I think Bobby answered it pretty well, actually. The only thing that I would add is that, you know, if we're going to be real, everything is really based on context. So if your interest is in what kinds of services might be best, one of the first things you want to do is look at the community that you're trying to help and see what services it is that they may need. So each community, based on whatever the social determinants are around them, housing needs, accessibility needs, whether there are resources or not, is going to determine what kind of strategy is going to be required to fill those needs. So you can find, if you're in a clinic, you can identify the needs that seem to be most prevalent among the people you see. If you're in an organization, you can identify them as the same thing. You can find the partner with whom you want to work on these things, and together you assess what is it that the community has that might be able to address those.
Great, thank you very much. And I'd like to thank all of our participants for your questions, and Bobby and Rebecca, thank you again for your presentations and your answers. As we conclude our web event, I'd like to bring a couple of additional items to your attention. For additional information on clinical community relationships, there's information available to you at the following websites. The first is AHRQ's Prevention and Chronic Care Program, which works to improve the delivery of primary care services in order to meet the needs of the American population for high-quality, safe, effective, and efficient clinical, preventive, and chronic disease care. And there are a number of resources available on that website related to improving primary care in addition to clinical community relationships work. In addition, I'd like to draw your attention to AHRQ's Healthcare Innovations Exchange. And the Agency for Healthcare Research and Quality created the Innovations Exchange to speed implementation of new and better ways of delivering healthcare and reducing disparities. The Innovations Exchange has a page entitled Building Relationships Between Clinical Practices and the Community to Improve Care, and this page is dedicated to understanding how partnerships among primary care and medical specialty providers, the community, and public health organizations are developed, strengthened, and sustained to improve care and meet the needs of patients, families, and communities. A link to the archived content from this web event will be located on this page next week. The page also features relevant innovations, perspectives from experts in the field, reports, a practical resource guide for building community relationships, and tools including the CCRM Atlas and Evaluation Roadmap that you heard about today in this webinar. So finally, I just want to say thank you. We really appreciate your participation. It was great to have you with us, and we hope that you'll complete the evaluation form that's available now to you through this page on the web event. So thanks again. Bye.